Well, thank you very much to all of you, wherever you might be across New Zealand and Australia, for calling in. For those of you who don't know me, I'm Rebecca Granger, a rheumatologist based in Wellington, and I'm delighted to be joined by my friend and colleague across the sea in Sydney, Erwin Lim. I'm sure many of you know him. Now, the Best of ACR Convergence webinar series has been developed by 9 rheumatologists and advanced trainees in rheumatology, and we reviewed all the abstracts for ACR, and there are quite a few of them, and we looked at all the presentations and posters and worked together to identify a summary of what we felt was the best research that was clinically relevant to practice in Australia and New Zealand. The faculty includes myself and Erwin, and on other nights this week, we each of us are joined by Helen. Last week, you might have heard from Dr. David Liu, Andrew Oster, and Ash Sudigo, the advanced trainees to whom we're very grateful. They worked really hard and covered a lot of material with us. Catherine Connolly, Shipka Day, and Kylan Pathmanathan. So, what are we going to cover tonight? The first 2 sections are on rheumatoid arthritis. I'll lead out, and my section will be looking at outcome measures, comorbidities, measurement of outcomes in rheumatoid arthritis. Then Erwin will follow on with some therapeutic focused abstracts. Then Erwin hands back to me to cover just a few slides on some of our less common connective tissue diseases. There wasn't a lot of material that we felt was highly clinically relevant, but there's a few gems in there. Then some slides on osteoarthritis and gout, which will be covered by myself, and then I hand back to Erwin to look at reproductive issues relevant to rheumatology. So without further ado, I will start off with the first slide, which was an abstract from a Dutch group that were really examining how often does that patient with arthralgia end up developing clinical arthritis. So this is a pretty common referral from the GP, aches and pains, maybe localizing to the joints, and is this inflammatory arthritis? These data are the analysis of 3 early arthritis cohorts in the Netherlands, where at baseline in these early arthritis clinics, they imaged a range of joints. 2 cohorts used ultrasound and 1 cohort used MRI, and they had strict and widely agreed definitions for evidence of synovitis. So they were really looking at the end point of who develops clinical synovitis after 1 year. Now, I think it's important to consider the 2 data sets separately, the ACPAR positive group on the left and the ACPAR negative group. So in the ACPAR positive group, between 44 and 68 patients in these cohorts did not have synovitis at 1 year. So those are the blue bars on the top. So you might say half to almost 2/3 did not have clinical synovitis at 1 year. In the ACPAR negative group, those numbers were even higher. 66 to 89% of patients with arthralgias and evidence of radiographic synovitis did not have clinical synovitis at 1 year. So this is interesting because there might be a temptation when you've got a patient with arthralgias that could be quite disabling, when you find imaging evidence of synovitis, to treat this. You know, the ultimate window of opportunity. They haven't even got clinical disease yet. And using something like methotrexate becomes fairly benign to us after a while. So I think this is encouraging us to really avoid over-treating and perhaps not start DMARDs when there's arthralgia. But the flip side of this is in the ACPAR positive group, you could also see that up to 50% of people do develop clinical synovitis. So we have to think quite carefully how we're going to approach these people. Maybe these are the group that we follow fairly closely and introduce DMARDs as soon as we find evidence of clinical synovitis. What's your take on this, Erwin?
I mean, since we decided to present this, I've been thinking about what I do, and I think we already kind of do this. So with an ACPA negative group in very early arthritis, when you can't actually, you're not certain they have got RA, I often don't treat. I just give them, come in 3 months or come in 6 months and we watch. But if it's an ACPA positive, let's say you've got an anti-CCP of 100, and they tell you they've got pain, and by the time they come to a rheumatologist, people don't waste their time or their money. They're worried by it. So, I probably would treat them. And if 50% of them actually have synovitis and a clinical synovitis in 1 year, I don't think I've made the wrong choice, right? You can treat them, feel that you've got them in remission, and then you can always have the option of taking the drug away if you weren't sure. So I think I'd still treat the ACPA positive group.
I think there's another slide, a few slides on, Erwin, that might be relevant to this idea of stopping drugs if you've started early. Yep. So thanks for that. We'll move on. Yeah, in fact, here it is now. So this slide, again from the Netherlands, examines this idea of sustained DMARD-free remission. So that's just a fancy way of saying no rheumatoid arthritis off medication. Now, I was thinking about this slide today, and I remember very early on in my rheumatology career thinking, gee, rheumatoid arthritis is quite bad. Only 5% of people will have their disease resolve off treatment. That was the kind of figure I had in my head for many, many years. So in this cohort, the definition of sustained drug-free remission is no rheumatoid arthritis signs and symptoms after 1 year off DMARDs with no flares on follow-up. So what they've done is looked back at this early arthritis clinic group, nearly 800 patients, and after 7 years of follow-up to see, well, what predicted this, magical sustained DMARD-free remission. Actually, it didn't actually occur all that frequently. Overall, in this early arthritis cohort, 19% of patients had sustained DMARD-free remission, but only 10% in the ACPA positive group, which was the biggest part of the cohort. So overall, sustained DMARD-free remission was 4.3% of ACPA positive patients. So I did think, actually that's kind of similar to what I always remembered, that proper rheumatoid, maybe 5% get sustained remission, but 31% in the ACPA negative. Now, the predictor of eventually having sustained DMARD-free remission was a more rapid decline of DAS28 in the first 4 months. So if you got a 1.7 unit decline, you are much more likely to get sustained drug-free remission later on. So one message from this might be that the DAS value at 4 months might be useful, and particularly the delta or change in the DAS value might be really useful in deciding if you can stop DMARDs at a later date. And I think this Kaplan-Meier curve actually, which is the sort of flip side round from the way we usually look at them, shows that this is the cumulative incidence of sustained drug-free remission organised by what was the DAS28 at 4 months. And you can see that the people who had a very low DAS at 4 months, less than 1.6, which is a really solid, no signs or symptoms, actually had a much higher cumulative incidence of sustained drug-free remission. So linking back to the previous abstract, one way we could think about this in those ACPA negative people with arthralgias but radiological synovitis, these data would suggest if you treat them and they get a really good remission quickly, they may well be the group that you can fairly confidently discontinue the methotrexate later. And you probably haven't done much harm by giving them maybe 6 to 12 months of methotrexate. And maybe it's skirting on the edge of the evidence, but I do have patients that I talk about. We could consider methotrexate and try it for a year. And if you're really good, we'll wean off over the next 12 months. That's probably pushing the boundary, but I think these data are beginning to say that might be a reasonable strategy in some people. Erwin, you were nodding. Do you have a similar approach?
Yeah, I think so. I mean, again, the more we go over this, then you start thinking about what this means, right? And maybe what this means is that when you're treating an ACPA negative patient, you're just treating a self-limiting arthritis anyway. And around 4 months, it's going to go away anyway because you managed to see them so early in your early arthritis clinic. I don't know, but I think we all say the same things, right? If a patient asks you, can I come off my medicine? If they're ACPA positive, you're going to say your chances are very low. If they're ACPA negative and they're doing really well, you're going to give them a Guernsey and you're going to try to take away the methotrexate slowly.
Yeah, great. Next slide. So we are all encouraged in our clinical practice to generate objective numerical measures of disease activity, so-called composite disease activity measures in rheumatoid arthritis. I tend to be reasonably good. I have the luxury of a public hospital clinic, and I'm teaching registrars, so I try and be on my best behaviour. So I do try and use a DAS28 calculated on my, an app on my iPhone. These slides are about the Clinical Disease Activity Index, which is a much simpler formula. All you need to do is add, and the Clinical Disease Activity Index does not require a CRP. It does require a patient and physician global, and these slides don't necessarily address how the physician global is measured when they're looking at distance assessment of patients, but we'll come back to that in a minute. So this is actually the combination of two abstracts. The first is from a Canadian cohort. It's got abbreviation Aubrey, I think it is, and it's basically community rheumatologists who push their data into a collective registry. It's probably not dissimilar to the OPAL initiative in Australia. So it's almost 1,500 patients in this Canadian cohort, and they compared the CDI with the DAS28. And the point of this being that the patient global is quite important and has a bigger weighting in the clinical, in the CDI than it does in the DAS28. So the CDI and DAS28 correlate pretty well when the disease activity is moderate or high, but poorly when the patient is in low disease activity or remission. So the trick here is if you are using the CDI for convenience, CRP, no CRP, or avoiding the tricky formula, if they do have low disease activity and you're wondering, do I need to escalate treatment? Can I get better control? Just see what the contribution of the patient global is, because we all know the patient global can be heavily influenced by non-inflammatory factors, pain syndromes, localized musculoskeletal disease, and other different health beliefs or expectations of patients. So the second abstract under number 2 is actually looking at the CDI derived from patient-reported tender and swollen joint counts and physician tender and swollen joint counts. They basically got patients in early arthritis cohorts to draw their tender and swollen joints on a homunculus with no training whatsoever. And there was actually more agreement at low joint count and low disease activity, and agreement overall about 2/3 of the time with low or high CDI categories. So in the plots to the left, these are Bland-Altman plots, and the numbers get bigger. So you can see they spread out as the numbers of these are swollen joints get higher further out. There's a much bigger spread or a much bigger difference. And this is putting that tender and swollen joint count into the MD, the doctor-derived CDI, or the patient CDI, and showing that it's pretty good at agreement and identifying active versus controlled RA. So I've done some work with patient joint counts, and actually the patients are reasonably close to us, and in our study, disease activity categories change really infrequently. Erwin, in your private practice, I'm wondering if you do these kind of measures. I think I've heard you say no, or...
I think you already know the answer. 2 years ago, you invited me to New Zealand to talk about outcome measures, and my talk was about how we failed to introduce it in private practice, and we tried to introduce the Rapid3. Our software allows us to do the DAS28, and the 10 rheumatologists in our practice, unfortunately, to my shame, it's 2 years down the track. Yeah, we use it sometimes, but it's not definitely every consultation with every patient. Yeah, something we have to improve.
Well, some of these data suggest that there might be a future when we actually get the patients to do most of the work for us.
Yep.
Well, I think we're going to see more and more about patient-reported outcomes because of the impact of COVID-19 in other countries, particularly North America. So we've been talking a little bit about rheumatoid arthritis in people with rheumatoid arthritis. Now we're thinking a little bit more widely about our patient group. Now, you've been hiding under a rock if you haven't heard discussions about use of AI in data in medicine. And this is an AI-driven study which looked at real-world databases from the Veteran Affairs and Market Scan and looked at 44 comorbidities and then programmed the program to interrogate and teach itself how to see groupings of comorbidities or find out if there were groupings of comorbidities within the patient groups. And this algorithm identified sort of 3 clusters of comorbidities. There's the cardiometabolic, so your diabetes, hypertension, lipids, and cardiovascular disease, heart disease, cerebrovascular disease. The second one was cardiopulmonary, so the heart and the lungs. And the third, found in both men and women, was the cluster of mental health and chronic pain conditions. And people with RA and people without RA had these similar clusterings of comorbidities. So there are more patients with these clusters of comorbidities together. And unfortunately, and we know this from our clinical experience, people with RA had a higher prevalence of the comorbidity patterns. And that's seen in the plot on the right, females at the top and males at the bottom, with the reference one being the non-RA. So increased odds of those different patterns of multimorbidity. I'd also just draw your attention at the bottom in the men, and we will have to acknowledge that this is Veteran Affairs, so they might be a particular kind of group of men. There was another cluster identified, which was mental health and substance abuse, which only came up in the male group, but that might be driven by the particular patient population that's seen in the Veteran Affairs system. So our patients have comorbidities, and there are these patterns, which felt had face validity for me for clinical practice.
Yeah, I think we discussed this last night as well, because, depending on where we practice, probably the multimorbidities are higher in certain populations, right? So Helen, who I presented with yesterday, works in Perth in a public hospital, and she was saying that she doesn't see a rheumatoid under the age of 60 who's not obese, right? And I'm fortunate that one of my practices is in the lower North Shore of Sydney, and usually they come in with one problem, and that's rheumatoid. So yeah, but I'm sure this is true. I do remember my hospital days, and definitely in my Parramatta clinic, which is Western Sydney, where people come in a bit later, they have more problems. RA is not easy.
I'm very jealous, because my hospital practice in New Zealand would be very similar to Helen's. And if you ever tempt me to move across the ditch to Sydney, I'll have your North Shore clinic rooms, please. I also like this because it's just beginning to see the application of AI in rheumatology. So next slide, Erwin. Okay, so we've just established that our patients have a lot of multimorbidity. So what does this mean for their treatment? So these data come from the RISE registry, which is a big centrally held registry endorsed by the ACR in North America, where rheumatologists, no matter what electronic health record they use, can transfer their data into the RISE registry. With the benefit for them, they get sort of quality assurance and tracking on their, almost like automated audit on their practice. But it also means we've got this really big repository, sort of big data for analysing what's going on with these patients. So this was looking at, well, what happens for treatment with people with rheumatoid arthritis who have multimorbidity? So what they did in this was used a medication-based surrogate for multimorbidity. So they didn't actually have the diagnosis, but by the drugs you're on can give something called an RX risk, which is a measure of comorbidity, and it's really based on the medications. They found patients with active disease, either defined by the RAPID-3, which was the bigger of the two cohorts, or the CDI, and who started a new DMARD and were followed for a year. So these were patients with active disease. And basically, people with RA had 9 to 10 comorbidities, and 50% of them were already on glucocorticoids, which is brings its own set of comorbidities. Now, the presence of comorbidities did not affect starting the DMARDs when disease was active. So that's great. We still give these patients a shot, even though they are kind of collectively quite sick. But unfortunately, patients with multimorbidity had lower odds of achieving remission or low disease activity. And you can see this in figure A, where in the cohorts there's no association of multimorbidity reducing the initiation of DMARDs, but when in the lower figure B, you can see all those intervals shoved out to the left, showing less chance of reaching treatment targets. So don't feel bad if you're trying really hard and your patient doesn't do as well as you might like.
Yeah, it also speaks to the fact that we all need, and this is hard to achieve, better ways to deal with the other medical problems, which we tend to, in a busy clinic, kind of skirt over.
And I suspect, Erwin, you know, we're expected, and even in public hospital practice, to push them back to primary care. And we find these days that our patients get quite variable types of service from their general practitioners, depending on a lot of different factors, what type of practice they're in, etc. So, yeah, it is a challenge. Okay, so staying with the theme of comorbidities, but looking at hepatitic steatosis. So I don't know, one of the most common emails I get from my nurses is abnormal liver function tests, you know, what do you want to do? So I was quite interested to see this because many of my patients, and Helen's patients, but not Erwin's patients, have fatty liver. And these two slides are examining this in patients with rheumatoid arthritis. So the first cohort is from a hospital in Pennsylvania from memory. And, oh no, sorry, it's New York. And they have analysed liver CTs on a large group of patients, 230 odd patients with rheumatoid and 6,000 without rheumatoid. And I suspect these data are like just a subset or a snapshot from a larger study. And on CT, you can diagnose fatty liver based on the Hounsell units, the HUs. So an HU of less than 48 suggests a fatty liver. So the bottom line was steatosis was much more common in people with rheumatoid arthritis than people who did not have rheumatoid arthritis. And in figure 1, that's actually frequency of Hounsell units less than 40. So this is very definite fatty liver. And you can see RA in the black with the wider confidence intervals compared, I don't know where you're pointing, Erwin, it's way down here, mate. I can't point because it's your screen. But in figure 1, in the adjusted, you can see that the people with rheumatoid with the black square and the big bar, much more likely to have steatosis. In the alcohol intake was more strongly associated with steatosis and rheumatoid arthritis, but reassuringly for us, current use of DMARDs was not associated with steatosis. So, you know, if you think you're getting a lot of abnormal liver function tests and you're wondering if it's the fatty liver rather than the drugs, you may well be right.
I was just playing with the mouse. I didn't realize you get to see it.
Oh, no, I can see it. I can see it. I don't know if our attendees can see it. Maybe that they can mention in the chat. Never mind. I could see you furiously pointing there. So the second abstract, this is people with rheumatoid arthritis, ultrasound proven non-alcoholic fatty liver disease, followed up for roughly 10 years, case control study matched 3 to 1. The patients with non-alcoholic fatty liver disease, not surprising, higher BMI, higher triglycerides. The 92 patients with non-alcoholic fatty liver disease showed no difference in the cumulative methotrexate dose compared to those without non-alcoholic fatty liver disease. And the prevalence of non-alcoholic fatty liver disease is not different across the different strata of methotrexate cumulative usage. So I guess as there's the patients that you're worried, you've got them on methotrexate, you know, their transaminase is just that little bit up, you know they've got a fatty liver and you worry. But this suggests that that's not associated with cumulative methotrexate dose. And I can see David Lou's telling us that they can see it.
The difficulty in practice is, yes, it won't stop you using the methotrexate, but if the liver tests start getting worse while you're on methotrexate, you're still going to be nervous, right? You're still going to play around with reducing methotrexate or stopping it. So yeah.
Yeah, look,
but it's
absolutely.
nice to know.
I think over time we've gotten more tolerant of the abnormal liver function tests. And when you and I are old enough to remember, you know, talk of liver biopsies after being on methotrexate for a certain period of time. And I think our young trainees would say, what? And the advent of FibroScan, we don't know quite where that's going to fit in, but that may have a role sometime in the future for assessing for fibrosis in people with these long-term minor transaminitis, but that remains to be seen.
Okay.
Okay, so we're sticking with the multimorbidity. I mean, this is our big challenge, the really sick patients we have to deal with in some practices, Erwin. So this again is from the RISE registry, which I described earlier. And I guess the benefit of this is routine clinical data. This is not clinical trials patients. It's just your bog standard Americans coming to see their rheumatologist. Now, in this study, there was a sort of big data approach, and they compared the comorbidities in rheumatoid, psoriatic, OA, and gout who'd had more than 2 visits. So these were sort of established patients, not your 1 or 2 visits, and used this treatment risk comorbidity score again. And if you look at the table down the bottom, the 4 columns are the 4 different diseases, and look, really large numbers of patients here. And the percentage of patients who had a score of more than 5 in the risk factor classes, which means they've got significant multimorbidity, all of them above 70%. And then if you look how many classes they have in the treatment risk category, which is sort of saying, well, I know those 2 medicines are basically for hypertension and this one's for cholesterol. So it sort of gives a surrogate of how many different classes they have. You can see that, again, they all have 7 to 8 classes. So multimorbidity is highly prevalent in all rheumatic disease. If you just go to the next slide, Erwin. So these are the data presented graphically using rheumatoid arthritis as the reference. So we already know people with rheumatoid have a high prevalence of comorbidities. If we look, psoriatic arthritis about the same, OA a little bit less, but look at gout compared to rheumatoid arthritis, more prevalence, more burden of comorbidities. So it's kind of interesting that the rheumatic disease that might be sort of less exciting, maybe harder to get into clinic, may not be referred from primary care or hospital practice, are actually our sickest patients in terms of comorbidities.
Yeah, it's a bit frightening, isn't it? And you made the comment to us that it's no wonder we're so tired after rheumatology clinic. You know, if all our patients have 7 or 8 concomitant issues, geez, it's hard work.
That's
right?
certainly what I said when I first saw these data. So yeah, it is hard.
I've saved this abstract because if ever Medicare comes looking and they don't like the fact that we use too many 132s, and for your Kiwi colleagues, the 132 is an item number that pays you a bit more from Medicare because you have comorbidities. You've got this data that shows virtually all our patients have comorbidities.
Yeah. I'll tell you what you do, Erwin, you just calculate the DAS28 in all your letters and add it to patient monitoring, and everyone goes, wow, you do all that in your clinic, man. All right, so, oh, wow, okay. I get a break. I'm going to hand over to you now.
You get a break. We've actually already hit 30 minutes. There's no kind of burning questions, I don't think. So I might just remind everyone, you can ask questions. I'll try to get through this section, and then we'll have a lot of time for questions. Okay, I like this paper. We all have patients who are on low-dose steroids. And, you know, when I was training, there was a belief that, you know, leaving someone on 2 or 3 milligrams of prednisone long-term is probably safe. And, you know, I still do that. And sometimes you have patients where you just can't take it off because even reducing by 1 milligram, they feel lousy. So this was a French study from the ESPOIR cohort of early RA patients. There were 813 patients naive to DMARDs or glucocorticoids that entered this ESPOIR cohort. And then they followed up 10 years. For 10 years, 608 RA patients who had no prior event history, and the events that they were looking at were all obviously death, CVS disease, severe infections, and fractures. Now, of that group, the majority, 65%, were given glucocorticoids at least once. And I think if you think back to your own practice, that's probably correct. right? We usually use some. We probably don't use the European doses, but we do give a trickle in a little bit to make people feel better and to get their trust and you know, allow them to feel better while we wait for methotrexate to work. The median dose was 1.9 milligrams. The mean cumulative dose was 8.47 grams. Now, 8.47 grams sounds a lot, but if you look at that orange box there, 8.4 grams is really only 5 milligrams a day for 5 years, or it's 2 or 3 milligrams for 10 years. And you know, if you think back to your patients, you will have some of these. And if they have that cumulative dose, 1 in 4 will hit that composite outcome of, you know, mortality, CVS disease, infections, or fractures. So interestingly, there is a clear-cut cumulative effect, which you would expect, and there's a time-dependent effect. Look at table 1. The longer you're on the prednisone, even if it's a low dose, you'll see increasing hazard ratios of developing the composite outcome. Now, the main kind of problem with this study was that the group that had glucocorticoids, you know, had more active disease. So they were the ones that you would give steroids to. But I think it is a reminder, right? Even low dose steroids cause problems. So where we can, we should try to use steroids short, sharp, try to take it away, use it in bursts, but don't leave people on it long term. Yeah, you agree, Rebecca?
Yeah, I do. And actually, we are in our hospital, we have these like health pathways, so you can check up what you're meant to do in specialties that you don't know so well. And I was digging around in the endocrine one, and they had a recommendation for testing morning cortisol, and for patients who are on low-dose glucocorticoids, and if it's above a certain level, they say that, well, they've got a reserve and you can stop it. So I think, I mean, you could look up for your local area, but it was like no steroids for 12 hours if their morning cortisol, quite a narrow time window. I'm actually using that strategy to convince people that they'll be okay to stop. And I've found that quite useful because they get very used to being on it, you know?
Yeah,
and the other thing is treating any comorbid conditions. You know, if they've got, oh, every time I come off my steroids, my shoulder hurts. Well, like, treat the shoulder. They've probably got, you know, rotator cuff or a bit of bursitis. So, yeah, you're nodding. We've got the tricks now.
Good.
Great.
All right, this paper, it's a SEAM-RA study, and it is my favorite, and I think it's close to your favorite as well, because we both kind of went for this abstract. And look, we all know the mantra: when you're using TNF inhibitors, you need to use methotrexate together because, you know, people do better. But the reality is, when a lot of patients, at least in Australia, are on TNF monotherapy once they do well. And when we looked at our own group's database, it's about 40% of those treated with RA are on TNF alone. And that isn't because the doctor doesn't know the data. It's often because when patients feel really well and they're doing, you know, well, they tend to forget taking the methotrexate, and then they forget it long enough, and then they kind of accept they don't need it. So this is a trial which has real-world implications. They took a bunch of people who were in very good remission. They used SDI less than 3.3. There was a run-in period of 6 months. Where the patients were followed up to ensure that they remained in that good state before they were randomized. And they were randomized in a 2-to-1 way to etanercept with the methotrexate taken away. The second group had the methotrexate continued, but you took away the etanercept. And the third group was etanercept and methotrexate just continued. They did allow prednisone at low dose, but it was still a minority of patients who had it, and it was quite low dose. And the primary endpoint was SDI maintenance at week 48. So let me show you the results. So let's start with the combination therapy group. It shows you that even if you were in SDI at a starting point, you know, it dropped down to 52.9% in SDI remission. So most of the people who lost SDI remission were still in very low disease activity. Look at the etanercept monotherapy group. So even if you dropped the methotrexate and you were just on once weekly etanercept, you were basically statistically non-inferior to the combination group. And that's reassuring. So, I like papers which kind of justify what we do, but, it looks good. And if you look at the methotrexate monotherapy group, not so good, right? About 40% worse. Flares tended to occur in the first 3 to 6 months. The good news is that if you did flare, almost all recaptured remission. I think 70% got SDI less than 3.3, but the vast majority entered a low disease state by reinstituting the combination therapy. So, this is a useful study, Rebecca. I mean, what do you think about this?
Well, the patients say, look, I'm so good, I'm near normal. The patients who don't just stop it themselves still ask, do you think I'd be okay to stop? Which one should I stop? And now we can tell them with some confidence, but also reassure them, look, when you get a niggle that it's coming back, that might be the time to think about reintroducing the methotrexate. The other question that isn't answered, though, is what dose do we reintroduce the methotrexate at? Do they need it back on 20? Can they get away with 10? I don't think that's been answered by this study, but it's worth thinking about.
And also this looks at a SEP, right? So I think we were talking and we were a bit worried about what if you gave them a MAB, right? Is the methotrexate more important in that case? There's a bit of a push in Australia at the moment to dose reduce biologic DMARDs, and of course, instead of taking away either drug, you could just go to etanercept every second week, right? That's money, less drug. But the problem with that is you're still on 2 drugs. And, most patients, at least the ones I treat, like a more minimalist approach. And when they can drop something, they like to drop it. And unfortunately, even though rheumatologists love methotrexate, patients do not.
Yeah, they'll vote with their mouth, I guess. No methotrexate.
Exactly. So this next paper is Australian driven. It's from the OPAL dataset. For those of you in New Zealand who might not know this, the OPAL group is about 110 Aussie rheumatologists, and they share the same electronic medical record, and they can pull quite nice data from it. And this is actually a combination of 2 abstracts. And if you just look at the methods and the results is from the first one, they tried to look at prescribing patterns of specialized DMARDs from 2 different 5-year periods, January 2010 to end of December 2014, and then they looked at January 15 till about now. And if you now go to the results section, you'll see that in the first period, the vast majority were treated with TNF inhibitors, which will not surprise you, 62%. There were people placed on tocilizumab as the next one, 17%, which again makes sense for those people, particularly who don't tolerate methotrexate, 15% abatacept, 5% rituximab. And in that time period, because of the choices you had, you can see that 58% of patients in this group received receiving a TNF in first line. When they did swap, they swapped to another, they cycled to another TNF for second line. Now, fast forward to the last 5 years. And what you'll see is the 28% prescriptions for a JAK inhibitor. So I think Australia is, one of the most avid taker-uppers of JAK inhibitors. And you can see it, at least in this group, it's reflected in my own practice as well, I will say. And because you have the JAKs, you can then see that TNF inhibitor cycling has reduced, okay? And in this database, they at least collected the switch reasons, and they had four categories. 47%, about half was lack of efficacy. That makes sense. A quarter was this better alternative, and it's quite interesting to work out how people think what is better. 20% was an adverse reaction, and the rest were other. So again, I think that's probably right. Sometimes we change the drugs because a patient wants to try something else, or it stings a little bit and you're swapping. So maybe those are reasons. Now let's go. I do find
the better alternative and the adverse drug reaction kind of interesting. I don't see that many adverse reactions with the subcutaneous TNF inhibitors, and better alternative. The patient. It's interesting to reflect what they mean, and I suspect there's going to be a lot of patients who might prefer an oral agent.
I can take a guess for it because in Australia, we're a bit spoiled for rheumatoid arthritis. I think we've got 13 agents, right? So a better alternative might be as simple as etanercept, Enbrel etanercept to Brenzys etanercept, because the paperwork requirements are much less, right?
Yeah.
And also because we are spoiled for choice, we swap a lot more. You know, a little bit of pain with Humira, you might swap to something like Simponi, which has less pain with the injection site reaction, you know? So it might be something as simple as that, yeah. So figure 1 is also quite interesting. It comes from a second abstract written up by Jeff Littlejohn, and it looks at the initiation of JAK inhibitors every time a new JAK inhibitor comes on the PBS. So the blue line is tofacitinib, and you can see that at least in the OPAL group, it was taken up with gusto, right? When it came on during that time period, 1/3 of scripts were for tofacitinib. Then you had baricitinib come on, and again you saw a spike, and of course you saw tofacitinib prescription drop. And then finally we had UPA come on in, you know, just before COVID really hit, I think. Yeah, we had the familiarization program, and then we had it on the 1st of May. And you can again see the spike and a corresponding drop of baricitinib and tofacitinib. You know, what does that say about us? Do we like to use new drugs? Or is it the OPAL group? You know, again, my disclosure is my usage very much reflects this. Yeah. Okay. So this was really an intro slide because the next few abstracts all deal with JAKs, because you couldn't go to ACR Convergence and not see a JAK abstract. One of the worries with JAKs, and of course we still, you know, love the TNF inhibitor class, is that we don't have enough long-term data with JAKs. Well, this tries to address it. It's Olumiant's baricitinib data up to 8.4 years. There's data from all the 9 completed RCTs, and then this one ongoing LTE. And I think we all worry about 2 very special kind of potential side effects, that of zoster and VTE. And this one tries to address VTE basically. And if you look at the timeline, thankfully, there is no increase in DVT or PE over time. So that is relatively reassuring, right? And look, it's still something we're going to be worried about. We're still going to be picky about the patients that we choose these agents in, but it's nice to see. Yeah, I'll show you the next one, which is the same kind of abstract, but if you look at the herpes zoster, clearly zoster is a bit higher, but again, there is no signal of it being a bigger problem over time. When you look at serious infections, that's quite interesting. There is a difference depending on age, so the older patients get more infections, and I think we see that in our patient cohort, but there is no real difference between the placebo group, the Bari 4 milligrams, or Bari at 4 or 2 milligrams, and that's interesting. So that's the data. That wouldn't be what I would have thought, but that's the data being presented. Any comments on that, Rebecca?
I think the only thing I'd say is when you look at the 2 Bari columns in the serious infection by age group, in the 0 to 24 weeks, although it might not be statistically significantly different, it looks slightly higher in the under 65s, and it probably is higher in that shorter time frame. And the TNF data would suggest that the biggest risk for infections is in the first 6 months after treatment. So that may well be catching that. And those are the people who are just constitutionally susceptible to infections, you know, a bit of lung disease, that prosthetic, you know, the one we all fear the most, the prosthetic joint that becomes infected. But the biggest risk is early, and that might be that as well.
Okay.
Yep.
Now another VTE trial, okay, because you know that's something that holds people back. And this was looking at the UPA program, and it looked at all their quite extensive select studies. And I mean, the figure says I mean, the figure tells you the conclusion. Essentially, UPA 15 milligrams, UPA 30 milligrams, and in Australia, we get to use the 15 milligram dose daily. There was no increase when you compared it to the two major comparators, which was the methotrexate monotherapy group and the adalimumab group. Now, that is good to see, right? And sure, we need more time, we need registry data, but it is very good data and it's reassuring, and it's something that I would tell patients. And the only kind of proviso is that there were only 35 adjudicated VTE events. So very low event numbers, even though there was quite high patient numbers. But I think, you know, we'll just keep watching this space. And I bet you next year there'll be more data presented.
Yeah. So there's no really worrying signal. However, we've always got to remember that patients in clinical trials are a sort of slightly restricted and curated group. They're not quite the same as the, you know, free-ranging patients we see in clinic. And I definitely agree that we need to see some real-world data, for example, from registries. And the Europeans and maybe the RISE registry will serve us up with that over time.
Yep. I wanted to contrast this good data, this reassuring data with a bit of problematic data. So there was a presentation by Kevin Winthrop just on herpes zoster risk in the same cohort of UPA patients. And I think, look at the results. UPA 15 milligrams, 3 times higher than the comparator groups, 5 times higher in UPA 30 milligrams. Okay, so clearly herpes zoster is more common. Good news is that the majority of cases are single dermatome and they're resolved, you know, relatively easily. When he looked at risk factors, he pointed out one particular one, the prior history of herpes zoster. Now, I'm not an ID physician, but what Kevin said was that he would have expected that if you've had prior zoster, because that's what happens in the general population, you actually are less likely to have a recurrent zoster. But this was not what they saw in this trial. No one can explain it. Is it some funny effect on the JAK inhibition? They don't know. The other thing is that there's a clear signal in Asian populations, particularly the Japanese. Okay, so zoster signal, definitely still a worry. It's such a pain trying to give people the Zostavax, particularly at the time, you know, the timing, particularly if they're on steroid, they're on other DMARDs, or they're on a TNF inhibitor and you want to swap them to a JAK. So I think the reality is we're not doing it. So we need Shingrix, right?
Yeah. You know, I thought of this slide yesterday at the end of the day when I was signing off all my TNF inhibitor special authorities for funding. I do them like each month when the patients have been. And I was signing one off and I looked at the age, and this woman was 85 and she's now been on a TNF inhibitor, I think since she was like, you know, 70 or something, or in her early 70s. And I thought, gee, you know, our patients are getting older, and it wouldn't be uncommon for us to maybe want to start a medicine on a patient in their mid-70s, but their risk of zoster must be going up quite a lot by the time they're in their mid-70s. So we just have to keep that in mind. I think patients, a 75-year-old in my mind now is younger, biologically younger than when I first graduated, you know, some time ago now. So, you know, patients are sort of biologically slightly getting younger, but we don't know what that means for things like zoster risk. Yeah.
Agreed. Okay, now I'm moving on to filgotinib. So this is of interest because this is coming to Australia in 2021. But the problem with it, well, the problem for the team running it is that it's the 4th agent in the same drug class. So, you know, why would you use the 4th agent when you have a very good agents already? Well, filgotinib, in terms of efficacy, have a very good trial. They've got some superiority measures over adalimumab. So the question is, can they differentiate on safety? Now, with this paper, up to 5.5 years of data, it looks good, right? It looks good. I mean, the same caveats, you need real-life data, you need extension trials, but look across MACE, herpes zoster, VTE, malignancy, both, you know, melanoma and non-melanoma, and it looks very safe, right?
Yeah.
And they try to argue that it's because of the JAK1 selectivity, whether it's that or something else, don't know, but they may have lucked out and got a very effective and very safe drug. Time will tell.
So the only issue at the moment is it's slightly been put on hold because of effects on spermatogenesis. So I think that's slightly on hold at the moment, but is compelling. Yeah.
Yeah. But imagine, there are lots of male patients who don't want to accidentally, have a baby. Yeah, that's a benefit.
Not necessarily.
Benefit. There's always niches. All
So
right.
in New Zealand, we usually get one agent in a class funded first. So it might be that when these come to New Zealand, there's actually a choice that one drug is funded, and it often comes down to cost, we're told, but maybe these kind of decisions might influence as well.
I think if you've got a very effective drug that's safe, you'd go for it. But of course, we need data. We need more data. So this was the last slide because that I picked, because when you have a new agent as well, we typically use it in patients where we've already tried other things and they failed, right? So this is a subgroup analysis, and they tried to look at filgotinib's effect in patients who failed 1 biologic DMARD, 2 biologic DMARD, and more than 3 biologic DMARDs. And the short answer is it works. Then they looked at people who failed TNF inhibitors versus those who failed IL-6 inhibitors, and it works. All right. So yeah, it's nice data to see that when you swap from a biologic to a JAK inhibitor, you get a decent response. Okay, that wraps up my section. Yeah.
Okay, ending over. So we got really excited and hoped we'd bring you slides on Scleroderma, Myositis, Sjogren's, and others. I must say it's rather restricted because there were not that many highly clinically relevant slides in this section, but let's see what we've got. So this slide is actually pretty exciting, showing a clear benefit for IVIG and active dermatomyositis in a double-blind randomized controlled phase 3 trial. So this is an impressive study in that it recruited 95 patients, relatively young, mostly female, mostly Caucasian. Majority had definite dermatomyositis by the Bone and Peter criteria. And these people were those hard to treat ones. They've got active disease despite standard immunosuppression, or they've previously failed or been intolerant. So these are, the bite your nails, worry about them patients. And the primary endpoint was proportion of responders at week 16. So there was a randomization where one group got placebo, and then after 16 weeks, all groups got IVIG, standard dose. There was a good response. At 78% of patients on the IVIG reached the primary endpoint compared to 43% in the placebo. Relatively well tolerated. I guess the biggest problem is the cost. We are fortunate in New Zealand that I've got a form on the internet I fill in to get IVIG authorised, and we already could get it relatively easily, but I understand in Australia it might be tougher, and these kind of data might be helpful. You have these every week in your practice, don't you, Erwin?
No, thankfully, no. I was just I'm glad to see the data, because I think will ask one of my public hospital friends when the next time I need this. Saying that, in the last 2 years, I've had 2 amyotrophic dermatomyositis with MDA5, and they're painful.
They're tough. They're tough.
Yeah.
Okay. So this is one to watch for. The next slide. Okay, this is another one that we get every day of the week in public hospital and private rheumatology practice, but it's one of those ones you always want to have in the back of your mind for those like strange presentations, IgG4 disease. So this is in a highly specialized clinic where they looked retrospectively at almost 200 patients that were referred, and they looked at the classification criteria versus the clinician diagnosis. And in table 1, what they show you is if the clinician was absolutely certain, most of them met the classification criteria. But when the clinician was kind of hedging their bets and they weren't sure, they often didn't meet the classification criteria. So the message I take from this is if I'm not sure, I'm going to pull out the classification criteria and see if that can help me approach the patient. The other important information from this abstract, which is really collating together those like tough, tricky cases, is that there were a lot of mimickers. They were mostly neoplastic disease, some autoimmune disease, strange things like, well, idiopathic recurrent pancreatitis, and interesting 4 cases of fibromyalgia. Curious. So I think the take home is, you know, those classification criteria are probably helpful if we're ever wondering. And if you're asked to consult on the tough case where this diagnosis has been considered, you know, do what rheumatologists are particularly good at doing, which is just go back through everything and don't hesitate to ask for investigations again, particularly rebiopsy if things are strange, because, you know, there's a fair amount of cancer that mimics these. You know, you can pull that out.
Yep.
You know, this is your little pearl to be the clever rheumatologist.
Fair enough. Oops, next one.
Yeah. Okay, again, you know, another very common condition in urban rheumatology practice in Sydney, me too here in Wellington, Behçet's disease, particularly looking at oral ulcers. This is the RELIEF study, which is an RCT of apremilast for, you know, really recalcitrant oral ulcers. It works, it's good.
Yeah.
It doesn't work. We're going to change tack a little bit. It doesn't work. So this tsDMARD is a monoclonal antibody against nerve growth factor, and there are biological rationale why this might help in osteoarthritis, but in fact, it's similar to non-steroidal. So I'm not quite right. It doesn't work, but if we go to the next slide, the problem with it is that it's got a safety signal that's a little bit worrisome. So the adjudicated composite joint safety endpoints were primary osteonecrosis. That sounds terrible. Rapidly progressive OA, type 1 or type 2, or a subchondral insufficiency fracture. I mean, all these things sound like a lot of pain to me and an early ticket to a surgeon. And they had 451 patients who got symptoms, and 145 were adjudicated to have had one of these very significant events. And the composite joint safety endpoint was higher in tanezumab. So I think although this works about as well as non-steroidals, we're not going to be using it in our patients anytime soon because of the safety signal.
Agreed. It's not going to get funded either.
No, it won't get funded. So we're going on the same theme. Very expensive, you know, designer drugs for osteoarthritis. This is a double-blind, placebo-controlled, randomized controlled trial in hand OA. Patients with, you know, 4 out of 10 pain and radiographic changes. But you can see from the pain VAS over the 12 weeks of the study, really no difference between placebo or tocilizumab. So again, another negative trial of a drug focusing on inflammation in OA. So the holy grail has not yet been found. I've got to say, for the large joint disease, you know, really we should be focusing probably on those public health measures. You know, I'm a big advocate for encouraging to patients to head towards a healthy weight, but exercise, even if their weight is not sort of low.
The problem with hand OA is that, you know, it's just so difficult and so debilitating. And while, you know, we spend this talk trying to talk about not using prednisone, it's one of the few things which has been shown to work. And in clinical practice, sometimes it rescues people. Yeah.
Work, but relapse as soon as you stop.
Of course. Yeah. Two-edged sword.
Yeah. Okay, so, you know, I was just talking about large joint OA, and all of us will have at some time, you know, injected with glucocorticoids an osteoarthritic knee. And you even have patients who come back, you know, periodically to get their recurrent intra-articular glucocorticoids. And these data are a systematic review and meta-analysis of RCTs and observational studies looking at the outcomes in terms of efficacy for intra-articular corticosteroids. So there were 14 RCTs and 2 observational studies. But you can see from that forest plot where it's kind of a little bit to the right, a little bit to the left, but all over sort of largely down the middle, actually the intra-articular glucocorticoids in these studies are no better at relieving pain than the comparator. The safety signal was reassuring, but these are probably not patients with recurrent injections, and we will need to look at the impact of that.
Injections are always a vex point. 17 years ago, I did my one and only locum for 6 weeks for a an excellent female rheumatologist who went on maternity leave. And I was amazed the number of OA patients who had regular 3-month appointments. They knew when it would run out. Then they came in and I had to give all the injections. And I don't actually care sometimes that it's a placebo because it kept them going for that 3 months. And yeah, I don't know how to use this data in my practice. Some people just, it seems to be magic and they need it.
All right, what do we got next? Okay, gout. All right, next slide. So this is data from Ken Kai working with Nicola Dalbeth in Auckland. And basically this is linking general practice data with hospital discharge data. And in primary care in New Zealand, we use a model for cardiovascular risk called the PREDICT. And they looked at how well the PREDICT score correlated with actual cardiovascular events. And what you'll see but basically what they found was that the PREDICT one underestimated the risk of events in people with gout. In that top figure 1, you can see that a lot of the dots are above the line. So the current cardiovascular risk predictions probably slightly underestimate the risk of cardiovascular disease in people with gout, particularly women. So again, this is looping back to these are the patients with a lot of comorbidities. You know, they're not well people. The gout, the old canary in the mine.
Yeah, we really need to get gout, you know, sexy again and talk about it more and get it in the public's mind. But yeah. How do we do that, Rebecca?
Well, in New Zealand, we can make it an equity issue because it disproportionately affects our otherwise underprivileged population in Māori and Pacific. And we are seeing some movement in that space. But, you know, the problem is large. You know, this is a lot of people we need to get better care for. We can keep chipping away. So next slide. Okay, so the CARES study gave us some concerns about increased cardiovascular mortality. And this is the FAST study, which aims to assess this, a non-inferiority RCT of people with chronic out from 3 European countries looking at cardiovascular outcomes with and basically it shows that in people without pre-existing cardiovascular disease there is no difference in cardiovascular events in treatment with febuxostat or allopurinol. 6,000 patients, appropriately powered, similar flare rate, slightly lower uric acid in the febuxostat group after randomization. But these are reassuring data, and we'll look out for this to be published in one of the really big journals. In fact, I think it's out in the Lancet already about the same week or the week before, so you can read it in full. Reassuring.
Yeah, important one to balance the cares.
Yeah. Okay, so these newer fancy oral agents for diabetes that are beloved of everyone treating diabetes, the sodium glucose linked transporter inhibitors. They've got big long names that I'm too old to have learned to say. You know, the drug didn't exist when I was young, so it's harder to get in your lexion now, but canagliflozin, dapagliflozin, empagliflozin. Am I hitting them, do you think, Erwin? The flozzies. So basically this is cohort study using electronic records from UK primary care. They're really good at these type of studies in the UK. They looked at people with type 2 diabetes with incident use of these agents, so they're starting. So they excluded gout patients and those without prior BMI assessment, and they followed up till they developed incident gout or switched to another agent, death, or the end of study. Big study, 22,000 patients, lots of drugs of the flozzies were used. And basically the risk of developing gout amongst patients treated with these agents was higher for canagliflozin and lower for DAPI and EMPA. So it's interesting to understand what might be happening here. I'm not sure if this is clinically relevant, but it may do something in uncovering our understanding of some of the transporter and the interaction with the sort of serum urate metabolism. Not serum urate, the urate handling. So it's kind of an interesting observation, and we'll look forward to seeing more about this. Okay, so this is interesting. Dual energy CT predicts mortality in gout patients, 3-year follow-up. So this is a cohort. They measured the volume of MSU with DECT, particularly around the ankles, feet, and knees. 130 patients followed up for 11 years. And they had follow-up data out to about 44 months or month 36 for quite a few. All-cause mortality was 12% during follow-up. You know, we've already said these people with gout have a high rate of comorbidities. But the point was that the volume of MSU crystal deposition at the knees and ankles, feet was an independent predictor of short-term mortality. So this is sort of saying the burden of gout crystals correlates with risk of short-term mortality. I'm not sure how we can apply this clinically, but it's interesting to understand a little bit more about the burden and the impact. And it just reminds us that, you know, once you've got gout, we really need excellent control of the modifiable cardiovascular risk factors.
Agreed.
Okay, so this is again looking at dual energy CT, which is still a newer modality that we're really sort of understanding. And this one's really about diagnosis. So basically on the dual energy CT, they have to arbitrarily decide what the cutoff is for the signal to say, is this MSU or is this another type of crystal, calcium, I think. So what they did in this study is identify that actually most crystals have a little bit of each, and where are we going to put the cutoff? And basically, if they applied the cutoff at the patellar tendon and the MTP, there was better specificity for gout and without reducing sensitivity. So it might be that in your DECT scans, you really want to know what's happening in those locations rather than other locations. And you know, sometimes I use DECT when there's nothing to aspirate and you really just want to clinch that this is gout, sometimes to prove it to the patient so they'll, you know, agree to go on long-term allopurinol.
But Rebecca, normally you'd image the incident joints, won't you? Wherever.
Yeah, but often the incident joint will be the foot.
Yeah, true. Okay.
Or possibly the knee.
Yeah, I think that's you. Okay.
Okay, back to you.
Yes, I don't think there's any questions apart from David Liu, who we're ignoring. And the next few slides are from Shikta Day, okay? And they're slides, and I think very, very relevant to clinical practice. So this is a collection of kind of two abstracts. And my first disclosure is I am very lousy at documenting contraception use. I mean, and to be honest, I don't really talk about it. I talk about pregnancy, but I'm not good at talking about contraception. So in the first study, they looked at, again, one of the databases, and there were lots of women who had SLE and RA patients. And what they found in the notes was that there was only 8.9% documentation of contraception use. Now, this is important because, you know, a lot of our patients are on teratogenic medications. And in this paper, they said that about 10 to 15% of pregnancies in women with rheumatic disease were on a teratogen. And I think we debated, but it's about 30% of pregnancies are unplanned. We think.
It's higher. I went back and looked at the data in New Zealand from, I think, 2016 national level data, and up to 40% of pregnancies are unplanned in women with chronic health conditions in New Zealand.
Yeah, it's kind of scary, isn't it? Do you document contraception in your notes?
You know, I don't know if this is a gender thing. I always ask about it at the first visit. And sometimes when you're then 5, 6, 7, 8, 9, 10 visits, you kind of like have to revisit. Did we talk about this, you know, and look back? And sometimes if my registrar's seen the patient first, I might, you know, naively assume that they've asked. And in fact, just on Tuesday, it became apparent that it had been asked, but the reason that it was been asked had not perhaps been explained as clearly as I may have. So I think it's something, you know, we should revisit.
Yeah. Well, because of this slide,
yeah.
Yeah, because of this slide, I asked on Tuesday one of my 20-year-old RA patients who's on Brenzis and methotrexate about, you know, contraception. And then she told me that, well, in March, I'm getting married and I want to fall pregnant. And, well, it took me, blew me away, but because I didn't expect such a young person would want to fall pregnant. And obviously, I then had to talk about methotrexate and what to do about it. So, yeah, I think this will be with me to ask people. Well, in this group, one of the striking things was the rate of documentation was 2 times higher in younger white women when they compared it to Hispanics and blacks. And why that might be, you know, that's a difficult question. Yeah.
Well, I guess it just reminds us, I mean, we don't know much about this particular clinic,
yeah,
but it does remind us that whether we believe we do or not, we probably treat patients differently depending on factors that we may not even be noticing. And we should be striving to find ways to cross cultural boundaries and become, you know, give everyone the same care and find ways to ask questions which we think will be appropriate for our patients who come from different cultures.
Yep. Now, number 2 looked at a method of making us, I suppose, address this better. And what they did was look at a university SLE kind of clinic, and an actual survey was given to patients, you know, at the start of the clinic, and they asked 3 simple questions. Would you like to get pregnant in the next 12 months? Which I should, you know, I asked my patient. Well, sorry, I didn't ask, but she told me, do you use contraception and what contraception? And what they found was 60.5% of patients use contraception. Women were interested in pregnancy. That's 1 in 6. So, you know, that's really important in a lupus clinic to actually kind of plan. And again, I know I'm guilty of this. I really should be raising it with my lupus patients a lot more. And one of the things I don't do is, unfortunately, even when I tell them to take contraception, I don't actually say you need to take very effective contraception or what are you actually using. And you know, I think you're much better at that from what you told me.
We try.
Okay. So next paper. Now, this is important because patients ask. We kind of have a spiel for rheumatoid arthritis, but I think there's very limited data for SPA and PSA. So this is, again, a combination of 2 abstracts. On the left side, it looked at SPA. On the right side, PSA. And they were both meta-analysis. And essentially, the data is not good, but among the articles that they chose for the meta-analysis, it looks like for SPA, there's increased preterm birth and small for gestational age in terms of the babies. Preeclampsia is a little bit higher, but look at the cesarean. Both elective and emergency was higher. There's also a higher risk for elective cesarean section. Now, go to the PSA data, and again, increased odds of C-section. The problem is there's not enough detail as to why the patient had C-section. You know, could it be patient factors, could it be doctor factors, or a combination of both? Who knows? But, you know, relatively reassuring, nothing too bad, I don't think. And with the second paper, at least, it also suggested that increased disease activity was more likely to increase the risk of preterm birth. So you want, like in rheumatoid, you want to get your patients as well controlled as possible before pregnancy. Do you have any other take-home messages from this, Rebecca?
No, just good to have some data that we can pull out. You know, nothing too shocking or surprising. It's sort of the signal of chronic disease rather than anything unique to the actual disease processes.
Yep. Okay. This is good. So this was a large electronic kind of health record again. And it looked at trends of medication use as well as trends of pregnancy outcomes. Let's talk about outcomes first. In this Nashville study between 1991 and 2017, disappointingly, the rates of preterm birth and preeclampsia had not changed. And that's surprising, isn't it? Because we all would think, at least we diagnose people earlier, we know how to manage them better. But unfortunately, rates, haven't improved there. When you look at the trends of medication use, and I know that's a busy slide, but there's a line here going straight up, and that's the use of antimalarials. So at least we've heard the message. Almost everyone with lupus should be on hydroxychloroquine, and you should continue it. You should continue it through pregnancy. You should continue it all the time. And I think at least that's heeded. Now, the problem is aspirin. Now, I didn't know this, but the American College of Obstetrics and Gynecology recommendations are that all female patients with SLE are at high risk for preeclampsia if they get pregnant, and that low-dose aspirin is warranted in all SLE patients. Now, I didn't do this. I don't do this, but should I be giving it? Obviously, when a patient wants to have a baby, I started, but what do you do, Rebecca?
Well, I guess the problem is at least 40% of the time it happens without being planned. But I guess in the people who come, patients with lupus who say, look, I plan to get pregnant, or I'd like to start trying to get pregnant at this time. Maybe we should think again about aspirin.
Okay. This is the final slide, and it's a goodie. So there's more and more information accumulating in IBD practices to support the safety of just continuing infliximab throughout pregnancy. Okay, but there's a paucity of data in a rheumatology world, and this is a study from Qatar. It was done in the largest tertiary hospital in Qatar, and they looked at both IBD and rheumatology clinics, and really bravely, they followed 30 pregnancies where the TNF inhibitor was continued throughout the pregnancy. So I think most of us probably try to stop it in that third trimester. Here, they just went through. And then they looked at the infants where they had enough data for at least 6 months, and that was 25 of them. And you can see from the results that 13 were given the BCG at birth, 17 were given rotavirus vaccine at 2 months, 12 had the MMR, and they had no vaccination-related complications. Now, I don't think, it probably won't change what I do. I probably would still stop it in the early third trimester. But if a person had bad disease, I feel more confident giving them this kind of data to say, well, you need it. Your disease hasn't gone quiet. Let's just continue it. So I think that's the take-home message.
I guess one thing is we don't tend to give BCG to all our infants where they must do it, or probably more frequently do it in Qatar where there might be more endemic tuberculosis. I guess it's the rota one that we would tend to ask our patients to defer. And I guess the thing would be the call you get from some GP who just says, oh my God, I've just given your patient's brand new, gorgeous, wonderful baby this rotavirus vaccine. What shall I do? And you can say, well, there was this one small study from Qatar that suggests they're going to be okay. So I guess that's the relevance here. And it's just kind of interesting. You really wonder if this was by intent or by accident, and we'll have a look at it. But it's an interesting one.
It's still cool. It's still cool to have the data, right? Because I don't think we'd do it in Australia.